Since the 1930s, over 35,000 alcohol-dependent individuals have been treated through taste aversion therapy worldwide. You might ask yourself, what exactly is taste aversion? Taste aversion therapy is where an aversive stimulus is associated with an unwanted behaviour to therefore extinguish it. For example, if the unwanted behaviour is alcohol dependence, then it will be associated with an aversive stimulus such as toxosis. After many pairings, it is believed that the individual will acquire a taste aversion and therefore will not want to drink alcohol as often or at all. That any type of behaviour is learned, and therefore if we produce an undesirable behaviour, it can be unlearned with the appropriate measures. This type of behavioural therapy yields favourable results regarding a conditioned aversion to alcohol in many cases, which inevitably results in eliminating the behaviour. Taste aversion doesn't only work for alcohol, it can work as a behavioural therapy for a range of unwanted behaviours. Applying an aversive stimulus can be done towards many unwanted behaviours. Some of these examples could include applying a bitter nail polish substance to stop the individual biting the nails. Another may include associating electric shocks with gambling. Individuals, when participating in this, receive small electric shocks as they gamble, ultimately resulting in a revulsion toward the machine. These are just two of the examples of the many unwanted behaviours that taste aversion therapy can extinguish. Throughout the studies I researched, I found that 2 out of 3 of my taste aversion therapy studies in relation to alcohol were in fact multimodal studies. Multimodal studies are made up of 2 or more therapeutic strategies that coincide to help achieve abstinence. This signifies that there were other means of therapy besides chemical aversion that assisted the individuals in eliminating alcohol dependence. One of the other types of therapy used in the 2 studies was narcotherapy. Narcotherapy consists of the administration of the drug pentothal, formerly known as truth serum. After drug administration, they ask the individuals a series of questions about their level of desire in relation to alcoholic beverages, which is then used to evaluate the development of aversion to them. In 1990, James W. Smith and P. Joseph Frawley conducted the study Long-Term Abstinence from Alcohol in Patients Receiving Aversion Therapy as part of a multimodal inpatient program. This study was performed at the Schick-Shadel Hospital, which is situated in Santa Barbara in California. They aim to enhance the quality of life of their patients through emetic therapy to rid their dependence of alcohol. There were 377 participants all up that qualified for the inpatient program, but there were only 200 patients who were chosen for it. This is approximately 4 out of every 9 people. The 377 patients were only chosen if they had completed the initial 10 days of treatment at that specific hospital in 1983. Out of those 377, the 200 patients were subject to random sampling, meaning that they all had equal chance of being selected for the study. First, individuals were contacted and received a structured interview over the phone. Out of the 200 patients, 160 were successfully contacted. Although those other 40 patients weren't contacted, their chart-documented data was still incorporated into the study. During the 10 days of hospitalization, they received 5 immersion therapy treatments and 5 narcotherapy treatments, both given on opposing days. Alongside this, they were able to attend counselling components of the program daily. The aversion treatments were designed to make all of the smell, taste, and sight of alcohol absolutely repulsive to the patient. These were then followed by narcotherapy treatments, where the individuals were given the drug pentothal and required to answer questions regarding their level of desire toward each different alcoholic beverage. This assisted the researchers in understanding the development of aversion towards alcoholic beverages. Subsequent to this, they returned 30 days and 90 days following treatment for a 2-day reinforcement program, which consisted of 1 aversion treatment and 1 narcotherapy treatment. On top of this, they were able to also attend counselling, where they created their own aftercare plan. The results of this study were quite positive. As you can see in this graph, of the 160 contacted patients, 71.3%, or approximately 142 people, remained abstinent for at least 12 months. Furthermore, there was approximately 65%, or 130 individuals, who had remained abstinent since treatment, with a mean of 20.5 months. There was only a small amount of patients who were still drinking. This was a small group of 16%, or 32 people. From the 40 patients that could not be contacted, it was known that 22 people had relapsed. A strong finding was that the more reinforcement treatment programs the individuals utilised, the higher the abstinence rate. Those who took more than 2 reinforcement programs had a 12-month abstinence rate of 92%. This compares significantly to those who partook in no reinforcement treatments, with a 12-month abstinent rate of 27%. This could indicate there is a high correlation between number of reinforcement treatments utilised and abstinence rate. There was a limitation to this study, as they relied on the self-report on abstinence status of the patients. This issue has been debated among many researchers, but they concluded that as long as their reports of abstinence do not lead to punishments or consequences, they are accurate. Despite this, there was a strong level of reliability and validity presented in this study. As a validity check, 1 in 3 patients had their abstinence assessment compared to another assessment to ensure that there were no disagreements among results. It is also a reliable study, as the abstinence rates in this study are similar to those that were reported during some of the first Schick-Shadel treatment programs. This study was most relevant to my chosen topic, as it was the largest study out of the 3, and it yielded the most favourable results regarding to abstinence rates. Being a larger study, consisting of 200 people, it is easier to generalise it to the wider population. It is most relevant to my chosen topic, specifically because it did produce behavioural change in alcohol dependence in more than 3/4 of the 200 people. This specific study provided evidence to prove that taste aversion therapy can be an effective method to aid in long-term abstinence from alcohol. It has proved to be the most reliable study, as there have been taste aversion therapy treatments conducted at this hospital which produced results that were statistically similar. It has a strong validity check compared to the other 2 studies, which assists in the accuracy of this study and therefore makes it seem more relevant. All of these arguments add to the relevance of this chosen study in explaining how it is the most appropriate to use regarding my chosen topic. This study evaluates taste aversion therapy and how it can result in abstinence in individuals for a prolonged period of time. Behavioural therapy, being a common form of therapy, has shown to eliminate alcohol dependence in individuals in many cases in order for them to take control of their lives. Although emetic therapy is not the only form of therapy that can result in a behaviour change, it is a well-utilised method. The successful study conducted at the Schick-Shadel Hospital provides evidence that aversion therapy is just as powerful as counselling centre programs and can be expected to yield strong positive results in regards to abstinence rates. It provides evidence on how a study can be conducted in relation to chemical aversion and evaluates how effective it is. This study concludes that taste aversion therapy does produce behavioural change in individuals who are strongly dependent on alcohol.